Bridge Erie. We have a wonderful present. Thank you, WebEx. Um, I'm very excited about this presentation. We have an amazing presentation from a colleague at the Drug Policy Alliance. Melissa Moore is the Director of Civil Service Reforms at the Drug Policy Alliance, where she focuses on advancing policies that address the harms of the drug war and promoting solutions that center dignity, family unity, health, and well-being. Melissa's expertise and views on drug policy issues have been featured by CNN, the New York Times, The Hill, NPR, Political, Newsweek, and more. In 2021, she was named one of Crane New York's Business 50 Most Powerful Women in New York. And beyond that, Melissa, I have seen Melissa's presentations and the content that she puts together, so I know this presentation is going to be killer. And I'm excited for everyone to see it. So Melissa, take it away.
Thank you so much for that very generous introduction. I appreciate it. And thank you for inviting me into the space today. I'm really excited about it. And we'll have time for some presentation and then some time for discussion, Q&A at the end. So just want to note that for folks. Really thrilled to be able to join you today and for you inviting me in. So I'm Melissa, as Jordan said, I'm the Director of Civil Systems Reform at the Drug Policy Alliance. And just briefly, this is what we'll be getting into today. We'll have some background, and then we'll really dive into the focal point for today's presentation and topic. Then we'll touch on some of the takeaways of like where do we go with this information that we've gotten, and then have some Q&A discussion. And Drug Policy Alliance, just as some context for folks, we're the leading organization in the United States working to advance policies and attitudes that best reduce the harms of both drug use and drug prohibition and promote the sovereignty of individuals over their minds and bodies. We advocate for a health approach to drugs that gives communities the support that they need to live full lives, and against punitive approaches that destabilize people, block access to care, and drain communities of resources. So for my benefit, if folks are willing to, I see a little bit happening in the chat already. Thanks, Val. Just hoping that y'all would be willing to put kind of what field you're in or where your work is focused, so I can get a little bit more of a sense of who I'm talking with today. So I know that folks are coming from many different fields here, and it would be awesome if you're willing to share. So diving into just some background context of the drug war and how we got here, I think it's important to start off with holding the fact that substances have been continuously used across time and cultures. There's been a wide variety of social responses, from holding use as a sacred part of traditional ceremonies to personal rituals. And whether we like to admit it or not, and whether we refer to them as drugs or not, most of us, and many of us, use drugs, whether that's caffeine or alcohol, prescription medications, or other compounds. And most of us use drugs without any problems. Historically, our social and legal response to drugs hasn't always been criminalization. As you can see here, two of the most highly demonized drugs today, heroin and cocaine, were treated as medicines in this country over 100 years ago and sold at the counter at corner drugstores as common remedies for small ailments. And most people believe, like when I'm talking about how we ended up with our current structure around the drug war, but to be clear, and we acknowledge this, particularly with the opioid overdose crisis, prescription drugs and illicit.
Hey, Melissa, we're having some issues with your connection a little bit.
Stop the video of
I'm wondering if you turn your camera off.
Yeah, I'll turn the camera off. All right, let's see if maybe that, is that any better?
Yeah, we're hearing you clear again.
Oh, great. Okay, so I'll just say, oh, go ahead.
I feel like it's still a little choppy, no?
Well, keep me posted. I'll see if there's something else I can close out of. But hopefully this will work, or I can call in from my phone. So, in the US, drug policies have first and foremost been created around who we imagine or who we claim to be the people using drugs. The first explicit drug laws in the US were a vehicle to pass xenophobic, anti-Chinese, and anti-Asian laws. They weren't about the actual chemistry or pharmacology of the drug itself. And they focused on smoked opium in California. And by associating Chinese immigrants with opium use, they allowed politicians in the US to mark Chinese immigrants as others. Historians have actually shown that people in the US used opium before large-scale Chinese migration, but yet that was the narrative and that was the framing. And similarly with the next federal laws targeting cocaine and marijuana, which people in the Southwest in particular. And then we flash forward to President Nixon signing the Controlled Substances Act in 1970, which supposedly was classifying drugs into 5 schedules that were rated by medical and level of potential for abuse. But the classification ended up relying much more so on fear and stigma rather than science, pharmacology, and that remains in place. So, if the distinction between legal and illicit wasn't about the chemical composition of each drug or its effects, that should really give us some pause when we think about just our structure around criminalization. And I just want to highlight just a contrast. Between methamphetamine versus prescription Adderall. And Dr. Carl Hart, who's a professor of psychology at Columbia University, has showed that methamphetamine and Adderall, which its chemical name is D-amphetamine, are essentially the same drug in terms of their effects on the brain's neurotransmitters and their potential for abuse than methamphetamine, right? And I'll drop, for anybody who's interested, a link to a spot on our website where we have a little bit more of this history of the drug war in case you're interested. But now let's come into the modern context or contemporary drug war. Since 1971, there have been more than 41 million drug arrests in this country. And drug arrests are still one of the leading causes of arrest in the US. And every 35 seconds, someone is arrested for a drug offense in this country. And over 80% of those are for possession alone. And when we look at incarceration for drug offenses, it's declined slightly in recent years, but out of the almost 2 million people who are in prison and jail are arrested for a drug offense. And 1 in 4 people who are on probation And as we discussed, race has been embedded in the rates of use and sale across racial and ethnic groups. Black, Indigenous, and Latine people are targeted and arrested, charged, and incarcerated at higher rates than white people due to the way that policing tactics and disparities in the judicial system have played out. And that's why even though Black people make up 14% of the US population, they comprise 28% of those arrested for drug offenses. And that disparity is mirrored as we go from the federal level to the state level and oftentimes to the county level. And despite the federal government channeling billions of dollars to local and state law enforcement to do the supply side of the drug war, supposedly eliminating drug sales and possession and making millions of arrests, drug use rates among adults have pretty much remained steady, but due to an unregulated and increasingly unpredictable drug supply, drug overdose deaths have skyrocketed. Had 1 million drug overdose deaths since the current crisis, and overdose is currently the leading cause of accidental death in the country. When we look at New York, since 2000, more than 70,000 New Yorkers have died of an overdose. And in 2023 alone, there were over 6,300 overdose deaths statewide. I just want to hold a moment for the magnitude of that and everybody that we've lost. Okay, and diving in further, we see that racial disparities in overdose deaths mirror the extreme overrepresentation of people of color who are punished for drug offenses. When we look at state overdose data for New York between 2019 and 2023, we see that Black and Native New Yorkers had the highest rates of overdose death. And in terms of the trend line for overdose deaths, we see that overdose deaths among white, Hispanic, or Latino and Asian New Yorkers stayed relatively stable from 2020 to 2023, while the overdose deaths among Black and Native New Yorkers increased really significantly. And just for a moment on the intersection of treatment and criminalization. So we've talked about the racial disparities in arrests and incarceration for drug offenses. And this is, again, despite the fact that we have similar rates of use. And that's a contributing factor to the overdose disparities, along with access to care and treatment in community. But many people in jails and prisons do not receive appropriate treatment, counseling, or evidence-based care. And while they're incarcerated, people die of drug overdoses. They die because of dangerous withdrawal without medical, because of the unavailability of substance use disorder treatment and the lack of naloxone, which is the opioid overdose reversal drug. And when people cycle in and out of jail and end up back on the street without meaningful care or support, they end up at higher odds of overdose after leaving incarceration. And there's robust research around that I'm happy to follow up with and share with y'all. But shifting back to the criminalization and the consequences from drug prohibition and enforcement, I'm not sure if folks are familiar with this statistic that there are 40,000 collateral consequences resulting from a criminal conviction, and that's for anything, not for a drug-related offense, but those are included. And when we look at drug arrests and convictions, they actually saddle people with further lifelong barriers to services and care that can bar people from jobs, from housing, from higher education, and from voting rights. And the harms of the drug war extend far beyond the criminal legal system. So today we're going to be talking about kind of the nexus of these two and going even further and talking about how even if a person is never arrested or never convicted of a drug offense, drug war policies and practices can lead to the loss of civil liberties and the loss of access to life-sustaining supports for them. So we'll talk about this in daily life. Where systems like employment, housing, and education are really widely recognized as the building blocks of health, of stability, and upward mobility for people. They offer connection and financial security, knowledge and opportunity, and social services like public benefits and child welfare are posited as being able to help families and communities. And yet, unfortunately, because of drug war policies and practices, we've seen how the sort of logic of the drug war has really profoundly shaped these pillars of people's daily lives. And that's been the drug war coming in successive waves of federal and state legislation, which has meant that it's had an impact on these systems, and really moved them into a space of where having a connection with drugs can lead to harmful intervention or exclusion from access to basic needs. So for people who use drugs, and particularly Black, Brown, Indigenous, immigrant, disabled, and low-income individuals and communities, these civil systems are all too often sites of responses that are really quite punitive, and not always evidence-based. And that's what we're going to be looking at, is how when we have civil systems that have been designed to help, that people have gone into these roles and positions to help, like schools and social services, but we're in a situation where there are extensive barriers that make health and financial security and overall well-being a lot harder to obtain for folks. And for people who are navigating addiction and recovery, the sorts of harsh penalties that we see within these systems and the roadblocks can make their journey even harder when stability is really essential. So as we're talking about, the drug war is not just arrests and prisons and jails. It's reached housing offices, workplace HR desks, family court, clinics, and school hallways. Families are ripped apart over even suspected drug use. Individuals are deported for marijuana possession, even in places where it's legal. And essential needs like housing are denied to folks. And whether we're talking about rural towns or inner cities, across the board, these policies hurt individuals and families from all backgrounds. And when people are blocked from housing and jobs and schools and access to care, it impacts our communities deeply. So I want to touch on a couple of examples here. As we're talking about, housing is essential to ensure that people can lead healthy and fulfilling lives. Without access to stable, safe, and affordable housing, it's much more difficult for people to be able to navigate and access healthcare services, be able to secure employment and go to their job on a daily basis, and being able to obtain education and just generally maintaining their day-to-day routine. And when we look at public housing through a series of laws that began in the late 80s and extended through the 90s and are still in place today, the US has restricted housing access for people with drug convictions and also people who don't have a conviction or arrest and are suspected of drug use or activity. And that can be very nebulous at times. So the main vehicle for this is federal one-strike policies that encourage public housing authorities to immediately evict somebody after suspected drug activity. An eviction doesn't require arrest or criminal conviction. An entire family can be kicked out of public housing if one family member is suspected of using drugs, and even if that family member does not live in public housing themselves. Once somebody has been evicted for drug-related activity, federal law requires housing authorities to ban access to public housing for 3 years. And different public housing authorities across New York State have various interpretations of these policies and how they pursue them. When we look at private housing market, there are increasing accounts of landlords evicting people who overdose or people suspected of drug use or activity, even though they're not, those private landlords are not mandated to do so in the same way as under the federal one strike. And this can happen when the evidence of somebody's use is merely that an EMS was called to somebody's apartment if there was an overdose. And then there's also at the federal level something called the Thurmond Amendment, which denies people with a felony drug distribution conviction from federal fair housing protections. And so in New York, this exclusion encompasses people who were caught up under the draconian Rockefeller drug laws, which had extremely long sentences and were not repealed until 2009. So we're definitely still dealing with the long tail of that. But going back to eviction. We know from research that the period immediately following an eviction and the months after are hugely impactful in terms of people's health. Eviction increases the risk of overdose death, and it can also lead to homelessness, which complicates accessing treatment. And I want to lift up a portion of a landmark California study of people who are experiencing homelessness. And the researchers heard a common theme, which is that if participants saying if they were housed, they would be more able to prioritize their healthcare, including drug treatment. And just connecting the dots all the way around, that's because people who are experiencing street homelessness in particular can often lack transportation or a phone, an address to receive mail, or a way to access the internet. And all of that interferes with someone's ability to be able to get preventive health care or receive treatment for substance use. And the exhaustion of needing to manage day-to-day issues that housing can mitigate, like exposure to cold or heat or rain or snow, finding an electrical outlet, ensuring that belongings don't get stolen, and trying to find food and just a place to sleep or rest, can make it even more difficult to think about addressing health problems, taking medications, especially if there's been a sweep and those medications have been taken or destroyed, or receiving treatment for a substance use. So as a result, people who become homeless are more likely to have health problems than people who don't become homeless. And once somebody is homeless, they're more likely to have their health problems worsen and less likely to be able to seek the care that would address these problems. So when we go back to those policies around eviction that can drive homelessness, we're seeing what the compounding and sort of domino effects are across people's lives and communities. And drug tests are another example of how the drug war shows up in a lot of different places in civil life. I'll give a couple examples in a moment, but first I just want to ground us in the utility of drug tests, like what they do, and also what their limitations are. So, drug tests, biologic tests, can include a urine, a blood, or a hair test, and those can indicate if a particular substance, particular drug, has been taken in a given time period. And there are, kind of different time periods associated with those different tests. But overall, drug tests cannot measure a person's active intoxication or level of impairment at that moment. They're an indicator of metabolites in somebody's body from use at a prior time. So for example, a drug test could detect if somebody took opioids 2 weeks ago, but it can't assess if someone is currently impaired. The drug test also can't determine how often or how much of a drug a person uses, or whether they have a substance use disorder. That's something that is a clinical diagnosis that can't be done via a test. And drug tests don't shed light on whether drug use will impact a person's daily life or if a person presents a safety risk to themselves or others. And even if somebody doesn't use illicit drugs, we know that many folks are subject to drug testing on a routine basis, and that can be really onerous and expensive, and at times really humiliating for people. So it takes a toll, even if somebody is not testing positive within that. And in a lot of contexts, people have to secure transportation, potentially miss work or caretaking duties at the last minute, which can really complicate both of those responsibilities. And in some instances, have to pay for each drug test. So that's a particular burden for people who might be unemployed or low income. And additionally, for people who are navigating traumatic histories of abuse or domestic violence, the fact that in a lot of instances of a drug test, somebody is supervising or watching, and as they provide a urine sample, and that can be particularly impactful for people psychologically if they have those trauma backgrounds. So when it comes to work and workplace policy, in recent years, we've seen really important changes like Ban the Box, which restricts employment background checks and second chance hiring, really gain momentum. And that's key for people with a prior drug conviction. But whether somebody has a drug arrest or not, nearly a quarter of workers across the country face drug testing for work, even though there really isn't evidence around workplace drug testing improving safety or productivity within those workplaces. So employers and employees alike, understandably, I certainly want a safe, healthy, and productive workplace where I am and where my colleagues and other people who I care about work. But there's really a disconnect with the information that drug tests provide, which again is whether there are metabolites that demonstrate whether somebody has used a substance versus impairment, which could lead to safety hazards. And when we look at polling across the country, people broadly agree that in most workplaces, an employee's performance should be the metric that matters, not what they've consumed off the clock, just as we wouldn't monitor for most people whether they had a glass of wine after work 2 weeks ago. If we actually focused on what drives workplace safety, that would mean a much bigger focus on examining factors and contributors to poor safety outcomes. And that's lengthy shifts and staffing shortages that can leave employees exhausted and perhaps more prone to accidents and dangerous conditions for employees and so on. And for employees with safety sensitive roles, workplaces should definitely develop minimally invasive and evidence-based impairment policies and impairment testing policies, but that doesn't have to equate to a drug test. And there are far more effective ways to look at impairment. But just really showing that limiting and cutting off employment has negative health and financial impacts, not just for individuals, but for entire families and communities. And research has shown that having a stable job is a protective factor against overdose. And drug testing isn't only showing up as a barrier in the context of employment. Across New York and in Erie County, pregnant and postpartum people and their newborns are regularly drug tested without their consent. These tests rarely serve a clear medical purpose, meaning they're not done to diagnose a problem or provide different or better care to the pregnant person. And doctors have explained that to us, that instead they treat symptoms as opposed to needing a drug test as a diagnosis in most instances. And what happens next varies, but in a lot of instances, a positive result is reported to Child Protective Services, and often an investigation begins from there. And this is despite the fact that New York State Department of Health clinical guidelines recommend that healthcare providers obtain informed consent before drug testing and screening pregnant or postpartum patients and their newborns, unless an emergency requires otherwise. And they also clarify that drug testing is not required under New York or federal law. And that's because a drug test isn't a parenting test. Again, a positive test measures metabolites. It can't determine a parent's love or capacity to care for their child. And New York law recognizes this. It's well established in case law that a positive test is not a reason to suspect or report child maltreatment. And yet, New Yorkers and disproportionately low-income Black and Brown people and their newborns are targeted for these tests, despite well-documented government data that Black people and Black pregnant people do not use illicit substances more than any other race or ethnicity. And that's why the New York Attorney General's office is currently investigating these practices at private hospitals across the state as a civil rights violation. And the other issue here really is that rather than facilitating access to substance use treatment for those who need it, research shows that non-consensual drug testing has the opposite effect. It drives people away from the healthcare system. It can alienate women from the supports that they need to have healthy pregnancies, births, and families. And that's really why the Department of Health clinical guidelines highlight that quote, fear of stigmatization can prevent pregnant persons who use drugs from accessing care, including prenatal care and substance use disorder treatment. This worsens both parental and neonatal outcomes, end quote. And we also know that pregnancy and postpartum are key periods for people to make changes in their overall health choices and specifically their drug use. And when birthing people feel connected to care instead of punitive responses, we see better outcomes for birthing people and newborns. As things are now, we're missing opportunities to link pregnant people with substance use disorder care and effective evidence-based care. And test and report is really a major barrier to that. But there's a lot of work happening to change this, and this will sort of bridge us into our next segment. But nationally and also really in New York State, all across the state, upstate, there's a movement of doctors working to end these unnecessary and non-consensual drug tests during childbirth and during prenatal care, and instead focus on connecting pregnant and postpartum patients with the appropriate care that they need if they're navigating SUD. So what do we do with this? And this is the tip of the iceberg. I'll drop into the chat and then share with y'all afterwards a resource that you can dive into that goes into additional different systems and what the impact has been. But really, we've seen that since Richard Nixon launched the sort of contemporary war on drugs over 50 years ago, decision makers have responded to people who use drugs with punishment and racial profiling, stigma, not public health or evidence-based treatment. And if we recognize that a person's drug use or conviction history shouldn't be a condition for them being able to access basic necessities like housing and employment and more, then our policy should really reflect non-punitive social supports and care systems that help change the conditions that are contributing to and deepening problematic drug use and criminalization. There is extensive research on what works to help people who use drugs and have substance use disorders. And it shows that we need to treat drug use as a public health issue, provide access to evidence-based and effective drug treatment and care for those who are requesting it, and craft policies and practices to better buttress protective factors like housing, employment, and family and community connections. And for many, drug use isn't really the root of the problems that they face. It's a lack of affordable and safe housing, well-paid employment, affordable healthcare, and transportation, and a lot of these things that keep people from being able to be economically stable and healthy. So if that's our goal, and for people to be able to be well-functioning in their communities, then we need to identify and remove the sorts of barriers that are leading to exclusion and contributing to overdose deaths as well. So what does that look like? In terms of local level work, of course, Drug Policy Alliance is a national organization, so we're working at the federal level, trying to ensure that funding and resources are going into the sorts of evidence-based supports that research has shown work. And at the state level, but also at the local level, there's a huge opportunity, given the jurisdictions wield a really considerable level of administrative control in a lot of cases. So counties and cities and even individual agencies have the opportunity to be able to change policies and practices without necessarily having to wait for statewide legislation in a lot of examples. So I'll just touch on a couple of ways that can happen. In 2020, New York City's health and hospital system began requiring providers to obtain informed consent before a drug test on a pregnant person, and subsequently before testing a newborn. And then several private hospitals have also followed. This doesn't prevent a drug test from happening. It just says you have to tell a patient first. And it's really tied with the research on the outcomes that we were talking about just a couple of minutes ago around test and report. And within this really short time frame, from 2020 to 2024, we have the New York City Administration for Children's Services data that's been analyzed by a third party. and has shown the really tremendous benefit of just this simple change in policy that happened at the health and hospitals level. And it showed an 80% drop in ACS investigations alleging parental drug use for mothers of newborns, and a 90% drop for Black birthing people. And then along with that, we've seen a 37% drop in newborns removed by ACS. And that's, for any reason, but often test and report was at the core of a newborn removal. So that means more newborns are staying with their families. We're not seeing the sort of cumulative domino effects that happen from a removal. And importantly, the data do not show any negative impact on child safety from the reduced numbers of ACS investigations and separations. And birthing people and new parents in Erie County currently do not benefit necessarily from these types of protections, since it was done at the local level in New York City. But this really is an issue in Erie County. Buffalo News has reported on the impacts of non-consensual drug testing of moms in Western New York, and the editorial board has actually called for the passage of the statewide bill around informed consent for pregnant people. But you actually don't have to wait for that statewide bill. And happy to talk further about that. And just another example quickly of local movement that came before statewide action. In 2020, the Rochester City Council voted to end pre-employment THC testing, so the active component of cannabis, for most city jobs. And this was before the statewide bill to legalize cannabis passed in 2021. That included even broader protections for legal cannabis use for adults off the clock. And included private sector employees as well as public employees covered by the city council bill. But that move by the city council was really important in being able to ensure that people could access those, secure and good paying city jobs. So this has been, a lot of ground to cover in a relatively short period of time. And I'll put my information in the chat. I'll have it on the next slide as well. But just really wanted to wrap up with an encouragement, that we actually do have the power to make really significant changes. I mean, that drop of 80 and 90% that we were just talking about is hundreds and hundreds of families that are able to move in a very different way. People being able to access jobs because of the moves of city council are in a vastly different situation than they might have been otherwise. And uprooting the drug war from civil life is really a way that we can move away from relying on fear and punishment and exclusion, and instead advance approaches that are whole person based, that are well-being and rooted in dignity and not conditionality. So affirming care and support models that work for our housing programs, for family court, for hospitals, for schools. And if we want a world where every person is supported in keeping themselves well and their family whole while accessing what they need to thrive, then we need to really look at these sort of care first alternatives and whole person models, regardless of drug use, that meet community and individual needs outside of these sorts of drug war punishments. So I'll put my contact info up, and would love to, I'll take a breath and move us into the discussion.
Are you able to see the question in the chat, Melissa?
Oh yeah, here we go. What impact do residents with past marijuana charges have with their housing today? So it varies based on how recent the charge was, whether they are in public housing or have family in public housing that might have been impacted under that first strike federal law that we were talking about, and how the Public Housing Authority has handled it, or if they're in private housing or private market. So unfortunately, there isn't or perhaps fortunately, in that people are not all facing the most draconian consequences, but some people definitely still are facing a lot of roadblocks from having a prior charge. Within the Marijuana Regulation and Taxation Act, the bill that legalized cannabis in New York, I worked on it deeply, and one of the crucial components of it was looking at what the magnitude of harm from prohibition had been in people's lives and ways that we would be able to remedy that within the legislation. And so it included a process for actually creating expungements in New York State. Sorry, my computer paused for a moment. So we actually created an expungement process that hadn't existed previously in New York State, and people who had many different, and particularly possession and lower level cannabis convictions were able to have those expunged, and people who had higher convictions were eligible to have those reclassified and be resentenced based on what the new thresholds were within the law. So that did have an impact for people who previously would have faced barriers because of having a prior arrest and conviction for cannabis. They were able to effectively have that conviction record, in the case of expungement, removed. And then for those with it reclassified, that helped a lot. However, there's still certainly a lot of barriers that people face. And unfortunately, the sort of domino effect of a conviction and arrest has been a lot of economic toll for people, in the way that they also have faced a lot of barriers with being able to access higher education. Many of the people who were targeted and arrested for cannabis in New York State were under 25 and Black and Latino. So that's right in the age when you're figuring out what, in a lot of counties, it was the case that was like 80% of arrests. And I can go back and look at the data that we have and drop into the chat the report that we did on marijuana arrests in Western New York, just for historical context. But that meant that people then were blocked from being able to access college in a lot of instances. Had to disclose on federal loan applications that they had a marijuana arrest, or had to disclose on a college application that they had a prior arrest. Also, previously, before Ban the Box, had to disclose that on a job application. And so we see, this sort of additional dimension of harm where it's really not just about this low level arrest, it's all of these other economic impacts and impacts across people's family life as well. So that's a very long-winded way of answering. But yeah, there can still be a lot of impacts on housing and just people's ability to afford it based on what the economic toll was. And no, people do not have to pay for their own attorneys to have the record expunged. It was automatic within the bill for most types of offenses. For people who have immigration considerations, we see, just highlighting that cannabis still remains one of the top reasons why people are deported. Even if they're living in states where it's legal, even if that arrest was 20 years ago. And this has been the case prior to the current context around immigration enforcement and deportation. Unfortunately, for many, many years, this has been happening, and it's ramped up certainly even more. But no, for people with an immigration status consideration, they have to have their record expunged, not through the automatic process, in order for it to count and give them relief at the federal level. So happy to follow up if folks have more questions around that, because it is actually a really crucial difference. But for others, they do not have to pay for an attorney. For people who are going through the process of resentencing and reclassification, it can be a little bit different. But the way the bill structures it, the presumption is that people should be able to have that resentencing and reclassification if they put forward their information for it. Do DWI also have an impact on public housing? That is a really good question. To my knowledge, not under the federal one strike policies, which were more focused on illegal drug use or activity and arrests and conviction. I believe I'll have to follow up. I believe that DWI would probably come under kind of a broader like part of the statute that's under just like general safe place to live and somebody potentially being in violation of that, but we don't see it. In my experience, I've not seen that enforced in the same way as we see the enforcement around drug arrests and convictions for public housing.
Are there any other questions in regard to this or anything else? Any of the other civil legal reforms that DPA works on? I don't see anything. So we send out the newsletter, all of this stuff will be included along with probably some additional resources that Melissa has spoken about in the presentation. Thank you so much, Melissa. This was amazing. I really appreciate your the deep dive into the legal context of some of these things. It definitely gives, it really contextualizes things, I think, because when we work in this space, you know, we know these things, but the legal background is so helpful for a lot of our service providers to know. So thank you so much.
Absolutely. Thank you for having me. And you know, please, folks, be willing to reach out. I'm available anytime and happy to have further conversation.
Thank you so much, Melissa. You want to take it over, Jason?
Yep, I'm just working on sharing my slides here. Let me see. Okay, I might need to join from my laptop. Okay. Okay. All right. Can I be heard okay, Jordan?
Yeah, you're all set.
Okay, great. Okay, we'll get set presentation mode. Okay. Well, welcome everybody. This will be our January update for overdose data for Erie County. This time around, we're going to be focusing largely on year-over-year trends from 2024 to 2025, now that we have almost all of our 2025 data. So we're going to look at the total amount of overdose deaths in Erie County. We're going to compare that to state and national trends as of recent data updates. We're going to take a brief look again at overdose death demographics and toxicology. This is a new thing for this meeting. We're going to be looking at stimulant-related deaths, which we're very excited about. Then we're going to look at overdose deaths by zip code and look at those comparisons year over year, which zip codes have increased or decreased over time. Look at non-fatal overdoses over time, and then look at those year over year by zip code. And then we're going to compare those year over year comparisons of deaths and non-fatal reports. So for 2025, as of updates as of January 15th, we have a total of 239 overdose deaths in Erie County. 164 are suspected opioid related, 148 are confirmed, and 16 are waiting for toxicology. So the total number of overdoses for 2025 might fluctuate slightly as we wait for those confirmations to come in, but currently standing at around 239. And we have 75 overdose deaths that are confirmed to be non-opioid related. Looking at the state and national trends, The CDC published their estimates as on January 4th that contain estimates through year over year as of August 2025. So we use the August 2025 12-month period as our benchmark for Erie County. So as of that time distinction, Erie County had a 43% decrease in overdose deaths, decreasing from 421 deaths as of August 2024 in that 12-month period ending August 2024, down to 241 deaths within the 12-month period ending in August 2025. And you can see that since then, Erie County data has kind of flattened out, and that's currently around the levels we're seeing today. You know, it's very similar to the 239 deaths we've seen through all of 2025. So as of that August 2025 benchmark, New York State had exhibited a 35% decrease in overdose deaths, and the United States nationally exhibited a 21% decrease. So as of August, Erie County has been exceeding both the national and state level trends, which is a very positive sign. Although, once again, we are seeing those declines begin to slow down a little bit, and we'll see if that bears out in the state and national data as well. Looking at overdose death demographics, we can see here this is we can see each color bar is a different year, and it shows the percentage of the red bar is the percentage of each of these racial categories in the population, and then the blue, purple, and yellow bars are for each year as a percentage of overdose deaths. So we can see that the Black population is disproportionately affected by overdose deaths, although the disparity has decreased significantly in 2025. And likewise with the Native American, American Indian population, we see them disproportionately overrepresented, but that disparity has also decreased. This is looking at those same race trends, but as a population adjusted graph. So this is showing the disparities in another way. The bigger the gap is between these lines, the greater the disparity, and the higher this line is, the more disproportionately affected that particular group is. And so this is showing our Black, Hispanic, and white populations over time. We can see that the disparity was largest in mid-2024 and has closed since then. And currently we're seeing similar rates of overdose deaths among the Black and Hispanic populations. And despite the pretty good radical decline, the Black and Hispanic populations are exhibiting about a 2 times greater rate of overdose deaths compared to the white population. So a significant disparity still exists, despite the significant progress. Looking by age, we can see that this is the same population adjusted concept, but shown by age. We can see that the 40 to 49 age group is still the most disproportionately affected. And we can see that in recent months, we've seen an increase among the 30 to 39 age group. So that's the orange line there, upticking in recent months. It had been in decline, and then for quite a while, and then had flattened out, and we started to see it kind of climb back again. Meanwhile, the 50 to 59 age group, which is that dark gray line, continues to decrease. Looking at overdose death toxicology, comparing 2024 to 2025, we can see that cocaine, in the absence of opioids, has increased slightly from 17% to 20% of our overall overdose deaths. And overdose deaths related to both opioids and cocaine fell from 48% to 38% year over year. Keeping in mind that toxicology data is only available through October 2025, since we're still waiting on some of our toxicology confirmations. This is showing that pie chart over time. So the pie chart is like a snapshot. This line chart shows how each of these slices changes over time. So we can see that in recent months, deaths related to both opioids and cocaine have increased. So that is a reversal of the trend we had been seeing throughout most of 2024, where opioids and cocaine both being detected. That blue line had been falling, and in recent months we saw somewhat of an increase. So that's something we'll continue to monitor, but that is a pretty significant change lately. Simultaneously, we saw a decrease in deaths related to cocaine without opioids. It is interesting to note that those two lines, the orange line and the blue line, sometimes tend to move in opposite directions, potentially indicating changes in the drug supply or potentially other factors. So now we're very excited to be talking about stimulant-related deaths and taking a closer look at those. Among 2025 overdose deaths, if you look at the blue line, that's stimulants without the presence of fentanyl. That was 31% of our overdose deaths in 2025, and that is the highest that we have on record. Conversely, the red line, which is stimulants and fentanyl both being detected, was at 39%, which is actually the lowest it's been since 2020. Still the largest category, but decreasing. So what we can say from this is that stimulants as a portion of overall overdose deaths are increasing while fentanyl is decreasing. So fentanyl still plays a large role in the drug supply and in our overdose deaths, but stimulants are representing an increasing portion of this picture. They deserve some attention. It's important to note that a significant amount of our stimulant-related deaths are related to fentanyl. So this is showing from 2015 through 2025. We can see that there's about 70% of our stimulant-related deaths were also fentanyl-related, and about 30% were not. It is important to note that it is unknown if this is due to contamination, where fentanyl was put into a stimulant without the users knowing, or if this is due to co-use, people who choose to use both fentanyl and stimulants. So there's no way for us to really tell that from the toxicology screens alone. In terms of what stimulants we're seeing, the vast majority of our stimulant-related deaths are cocaine-related. 93% of our stimulant-related deaths in total are cocaine-related, and 13% were methamphetamine-related. And there is a small degree of overlap. About 6% of our stimulant-related deaths over the past 10 years were positive from both methamphetamine and cocaine, and another 7% were methamphetamine without the presence of cocaine. Looking at the demographic distribution of stimulant-related deaths, we can see actually different demographics tend to be affected by different stimulants. So our cocaine deaths disproportionately affect the Black population, and then our methamphetamine deaths disproportionately affect the white population. So we can see methamphetamine deaths on the left and cocaine deaths on the right, and we can see that the Black population is significantly more represented among cocaine deaths compared to methamphetamine deaths. Looking by age, we can see that methamphetamine deaths are most common among the 30 to 39 age group, and cocaine affects a broader range of age groups, with the peaks being 30 to 39 and 50 to 59. So very different age demographics here, and these are also shown on the same scale, so you can kind of get a feel for the difference in magnitude between methamphetamine deaths versus cocaine deaths. So yes, different age profiles being affected here. However, one interesting thing we did notice, this is now showing on the left all those the same cocaine-related deaths chart by age, and on the right we have cocaine-related deaths excluding all the ones that were related to fentanyl. So as we mentioned, a significant portion of our stimulant-related deaths are fentanyl-related, and we can see that here with these are on the same scale. We have a smaller number there on the right when we exclude fentanyl-related. But we also noticed that the demographics shift a lot older. The largest demographics for cocaine deaths excluding fentanyl are 50 to 59 and 60 to 69. So the deaths that are related to both cocaine and fentanyl do tend to shift younger than when we compare that to cocaine deaths excluding fentanyl. So interesting to note there that there might be differences in the drug supplies that these different age demographics are consuming. Now looking by zip code, looking at our locations in which overdose deaths are occurring. In 2025, these are the areas with the most overdose deaths. The largest two locations were 14215, which is the east side of the city of Buffalo, bordering Cheektowaga, and the lower west side near Allentown. Those areas both had 16 overdose deaths. The Black Rock Riverside area had 14 deaths. That's 14207. The Broadway in the city of Buffalo on the east side exhibited 12 deaths, 14212. South Buffalo also exhibited 12 deaths, that's 14220. And West Seneca, 14224, exhibited 11 deaths. So those are all the zip codes that had more than 10 deaths in 2025. And as we'll look at in a second, this does represent a significant decrease in most of these zip codes compared to 2024. So now we're going to look at the percent change in overdose deaths by zip code from 2024 to 2025. The areas in red are the areas where we've seen an increase in overdose deaths. The areas in blue are where we've seen a decrease in overdose deaths. Anything in gray was less than a 10% change from 2024. And anything not shown had not enough overdoses to measure here. And we'll go through this in more detail. So the areas where we saw the largest percentage increases, 100% increase or greater. So in these areas, the number of overdose deaths doubled or more from 2024 to 2025. And those areas were Orchard Park, Amherst, and Akron. And it's important to note that the total number of overdoses in these areas were relatively small compared to some areas like the city of Buffalo, but proportionally these increases were rather large. And it's also important to consider that overdose deaths overall have fallen significantly from 2024 to 2025. So anywhere where overdoses are increasing is a cause for concern. So 14001, 14221, and 14127 are the largest proportional increases. These areas saw fairly large increases, 50 to 60% increase from 2024 to 2025. Those areas include two areas that border each other, South Cheektowaga and West Seneca, 14227 and 14224. Those areas saw fairly large increases, and it is interesting to note that they do border each other directly. We also saw a significant increase in 14203, which is in the city of Buffalo in the Outer Harbor. So that was one of the few areas in the city of Buffalo where we actually saw an increase in overdose deaths. These two areas saw more moderate increases, from 20 to 30% increase in overdose deaths. But once again, even though these increases were rather moderate, this is amid an environment where overdose deaths are declining generally, so any increase is notable. And these areas are 14223, which is a part of Tonawanda bordering Kenmore, kind of in the Lincoln Park area. And also 14201, which is the city of Buffalo in the Lower West Side. Now we'll look at the areas that had decreased overdose deaths. The areas with the largest percentage decreases of 75% or greater were East Aurora, Springville, and West Amherst. So 14052, 14141, and 14228. And here we have the same note as we did for the areas with the largest percentage increases, where these were small numbers overall, but proportionally the decreases are large and worth noting on the annual scale. So now we'll see that the areas that had other large decreases, but not as large, 50 to 75%, is a very long list, which is really great news to see such significant decreases in so many places. This does include the majority of the city of Buffalo with these large increases, including most of the east side, parts of the west side, Black Rock. Many of our areas that were and still are some of our most affected areas by overdose deaths have seen significant declines over time from 2024 to 2025. So very, very, very significant progress, very positive signs in many areas. These are the areas that had more moderate percentage decreases from 20 to 50%. And that includes Lackawanna, 14222, which is the west side of the city of Buffalo, particularly near Elmwood Village. 14215, which is again the city of Buffalo, east side near Cheektowaga. 14204, which is on the east side, kind of near Michigan Avenue, closer to downtown. And also 14207, which is Black Rock Riverside. As we mentioned earlier, 14215 and 14207 are some of the areas that had the most overdose deaths in 2025. But they both had some decreases compared to 2024. So even our most affected areas are trending in the right direction. All right, so now we're going to move on to our non-fatal overdose reports from 2022 to present. These are based on police reports and emergency service calls compiled by our local HIDA office, the High Intensity Drug Trafficking Area Office. And I believe the head of our HIDA office is joining us today. So that is we thank him for all the work he and his office does for us. Yeah, we receive data from HIDA on a daily basis, aggregated from these law enforcement reports and EMS calls, and we use them for follow-up after overdose and for planning our outreach. It's important to note that not all overdoses end up being reported. So we're very grateful to HIDA for the data that we do get. It really does make a huge impact in the work that we're able to do, and we thank them for their diligent work. But it's important to note that there is underreporting, and we'll get into that a little bit more later. So this is showing by month the non-fatal overdose reports occurring in Erie County. The peak of non-fatal reports in 2025 occurred in July with 80 reports. We do notice a trend that overdose reports tend to peak when the weather is warmer out and decline in the winter months. So we can see here a repeating pattern over the past 3 years. We saw a continuous decline in non-fatal reports from September through December, where it declined each month. So a really significant relationship there, where as the weather tends to get colder, we tend to see fewer reports, at least in September through December. That was a trend that held through 2023, 2024, and 2025. So now looking at those reports aggregated over the course of the year, from 2024 to 2025, we saw a 21% decrease in non-fatal overdose reports, and we saw a 42% decrease in fatal overdose reports. And that's fatal overdose reports coming from HIDA, not from the medical examiner's office, just to distinguish that there. This is evidence of underreporting because, as we mentioned earlier, we had 239 overdose deaths in Erie County. Depending on probable cases, that's at least 225 confirmed and likely higher. But when we look at the overdose deaths that were reported, we had at most 154. 107 confirmed fatal reports from HIDA, even if all those 47 unknown outcome reports were fatal, we would still not account for all the deaths that we have confirmed by the medical examiner's office. And it's unlikely that all those unknowns were fatal to begin with. So we know that there are some fatal overdoses that are showing up in the medical examiner's office without having been reported. So that just goes to show that if that's happening for fatals, where we do have confirmation, it's probably happening to an even greater degree with non-fatal overdoses. So important to note that we can only report data on the actual data that we have reported to us, but that it definitely does not represent the full picture of overdoses that are occurring in Erie County. So yes. That being said, we'll look at the changes in non-fatal overdose reporting from 2024 to 2025. Again, red is increased non-fatal reports, blue is decreased non-fatal reports, and those in gray exhibited a less than 15% change year over year. So these are the areas that had the largest percentage decreases. These areas are largely concentrated in the South towns. That kind of big block of blue in the South towns includes East Aurora, Orchard Park, Hamburg, and Blaisdell, as well as West Seneca. So all those areas saw very large decreases of 50% or greater in non-fatal overdose reports. We also saw in the Tonawanda area, 14150 and 14223, some rather large decreases. And we also saw a significant decrease in the Angola area of 14006. So all those areas between 50 and 83% decreases. So lots of significant decreases there. These areas experienced other large decreases between 25 and 50%. So that includes Grand Island, West Amherst, the Broadway area, 14212, as well as Cheektowaga and Depew, 14225 and 14043, as well as 14221, which is Amherst in the Williamsville area. We also saw a significant decrease in 14209, which is in the city of Buffalo, kind of near Main Street, kind of right in the middle of the city of Buffalo. And these areas exhibited more moderate decreases. So if you've attended any of our Bridge Erie meetings or task force meetings in the past, you'll remember that strip of zip codes on the west side of Buffalo, from Black Rock to Grand Ferry to the lower west side, 14207, 14213, and 14201. So in all of those areas, we saw decreased reporting, which is encouraging because those are consistently the areas where we see some of the highest levels of reporting. And so we saw some decreases there as well. We also saw decreases in other parts of the city of Buffalo as well. 14214 in North Buffalo near University Heights, 14215, another one of our most affected zip codes by overdose deaths, city on the east side border of Cheektowaga. Lancaster, 14086, as well as South Buffalo, 14220, and 14204 on the east side near Michigan Avenue. Now we'll look at areas that had increased non-fatal reports, and it's really not that many, only 4 zip codes exhibited a 15% or more increase. Those include 14227, which is South Cheektowaga, Clarence, which is 14031, Springville down in the rural area in the south, 14141. And in the city of Buffalo, there was only 1 zip code that exhibited a significant increase, and that is 14208, which is on the east side of the city of Buffalo, kind of near Jefferson Avenue. So those are our increased non-fatal reports, sorry. Now we'll look at a comparison of our fatal overdose reports by zip code to the non-fatal overdose reports by zip code year over year. So on the left, we have that map of non-fatal overdose by zip code, and on the right, we have our overdose deaths. These next 2 slides are going to look at where these trends are moving in opposite directions. So here we have 2 areas where deaths decreased significantly, but we saw non-fatal reporting rise. And there are 2 very different areas. One of them is Springville, 14141, a very rural area in the southern part of Erie County. There we saw a pretty significant decrease in deaths, but an increase in non-fatal reporting. And we also saw that in 14208, which is, as we just mentioned, in the city of Buffalo, on the east side. So it's unclear why this might be. It could just be, just kind of general fluctuations in reporting. But it's also potentially evidence of harm reduction practices and harm reduction efforts and outreach efforts making an impact. And that could be why we see falling deaths there and more non-fatal reports instead of deaths. On the other hand, there were some areas where we saw non-fatal reports decrease, but deaths rise. This is kind of an indication, a potential indication of underreporting. If we are seeing overall reporting decline, but deaths rise, it's possible that there's other unreported overdose activity going on there. So those areas include Amherst in the Williamsville area, 14221. That Tonawanda zip code near Lincoln Park, 14223. The Allentown area, Lower West Side, 14201. As well as this block in the south towns of West Seneca and Orchard Park. So West Seneca and Orchard Park both saw very significant decreases in non-fatal reports, but rather significant increases in overdose deaths. So those are the areas basically where we see more deaths than we would expect based on the levels of reporting that we're seeing. And so potentially some underreporting going on there. So now to summarize our data points here. Non-fatal reports decreased 21% from 2024 to 2025, and overdose deaths decreased by 33%. So overall decreasing overdoses across the board. Stimulants played a larger role in Erie County overdose deaths in 2025 than in prior years. And we actually saw 37% more deaths related to stimulants than related to fentanyl, although it's important to note that those categories do have significant overlap. And the vast majority of stimulant-related deaths are cocaine-related, with the rest, pretty much all of the rest being related to methamphetamine. Different stimulants do tend to be used by different demographics. Cocaine tends to show up more among disproportionately Black and older populations, 50 and older, and methamphetamine tends to skew white and younger, disproportionately 30 to 39. In terms of location, the majority of City of Buffalo zip codes exhibited more than a 50% decrease in overdose deaths from 2024 to 2025, which is really great to see, considering how heavily affected the City of Buffalo is by overdose deaths. And then when we compare where we're seeing levels of non-fatal reporting compared to overdose deaths by zip code, the areas where we're seeing more deaths than we might otherwise expect are Amherst-Williamsville, Orchard Park, West Seneca, Tonawanda near Lincoln Park, and the City of Buffalo on the Lower West Side. And I'll also mention, I didn't include it here, but that South Cheektowaga zip code of 14227, we did see increased levels of non-fatal reporting there, but also a significant level of overdose deaths. Yes. So now just to talk about a couple of upcoming events. This is, we'd like to advertise our Trainer of Trainers program. So you yourself, if you're interested, can become a Narcan trainer. Learn how to conduct Narcan trainings for your organization or your community. I believe we just put a link in the chat to sign up for that. Or you can scan this QR code if you have your phone handy. Our next session is on February 11th from 9 a.m. to noon at the Erie County Training and Emergency Operations Center in South Cheektowaga. Yeah, it's a great opportunity to become more involved in harm reduction. I know several of the people who are currently trained trainers and are conducting trainings are joining us today, and we want to thank them for their hard work. Our external trainers that we have trained that are doing trainings have enabled us to expand the reach of our Narcan trainings by around 30% in 2025. So that's a huge increase in the amount of people we're actually able to impact with our Narcan trainings. So thank you to all our TOT people that have been conducting trainings in 2025. We really appreciate it. And lastly, don't forget about our data webinar that I will be conducting on February 23rd. There is a new QR code to sign up for. It used to be a Microsoft form, but now it lives on the county website. So we can put the link in the chat there, and where you can scan this QR code. In these webinar sessions, we look at overdoses on a level more specific than the zip code level. So we can actually look at specific parts of neighborhoods, specific intersections, and monitor these trends over time. In this particular webinar, we are going to be focusing a lot on year-over-year changes. So kind of the big picture shifts from 2024 to 2025, and we'll be able to say a little bit more specifically than the zip code where we're seeing these trends occur. You can ask questions, engage in a discussion about how these heat maps might influence your work, request specific maps for specific areas or timeframes that we might not have otherwise looked at, and you can sign up for monthly updates on our heat maps. We have an MOU that is non-legally binding, but that we sent out just to confirm that you intend to keep the heat map reports internal to your organization for outreach planning purposes. And you'll receive those on a monthly basis after attending a webinar, if you so desire. So we really are trying to get as many people as we can to come to this. It's a huge passion project of mine that I'm really excited about. So definitely sign up if you are interested. And that is all for today. Thank you very much. And if anybody has questions, we'll be taking those now.
I don't see any data related questions in the chat, Jason. So unless there's anything else, I'll just ask everyone in attendance, we did post a survey about this webinar that we offer, just getting some feedback and asking folks if they're interested in presenting. So please feel free to fill that out if you are interested. We would love to hear from you. And thank you so much. Have a great rest of your day.
Thank you, everybody.